didn't mention this earlier, but I did spend a few years as medical director of the New York City Fire Department, as a medical director for EMS. So I'm well versed in firefighting.
Unbelievable background, Liz. Hello, and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I'm your host, Lee Scheinbart, and this podcast brings you stories and wisdom from some of the best CMOs in healthcare today. The leaders on this show face some of the toughest challenges in healthcare today, and they will share with you their insights about the role and the responsibilities that come with the title of Chief Medical Officer. Today, our guest is Dr. Lewis Marshall, the Chief Medical Officer at Health Plus Hospitals at Lincoln Hospital in the sunny South Bronx. Dr. Marshall grew up in various places as his father was an Army physician, but most notably, he was raised in Washington, D.C., Chicago, Illinois, and Wichita, Kansas. He earned his undergraduate degree from Morehouse College in Atlanta and his medical degree at Howard University in D.C., and trained in internal medicine and emergency medicine at the Harlem Hospital in Manhattan. In addition to practicing emergency medicine and later becoming a CMO, Lewis also has the distinction of having earned a master's in health policy. He has an MBA and a Juris Doctorate, and he serves on the board of trustees of One Brooklyn Health, a public safety net not-for-profit hospital system in Brooklyn. Lewis, welcome to the show.
Thank you for having me, Lee. It's great to be here today.
It's a pleasure. So, Lewis, it turns out we have a few things in common. First, I lived only about a mile from Harlem Hospital on 120th between Amsterdam and Morningside while you were doing your residency in Harlem. And then fast forward about 40 years, and my current institution, the Burrell College of Osteopathic Medicine, recently signed an affiliation with One Brooklyn Health, where you serve as a board member, to be a teaching site for our third-year students during their core clerkship rotation. So how's that for a little strange magic between us?
A small world. You never know.
Small world for sure. I think our paths formally crossed when we met last year in Boston, arch rival of all things New York, by the way.
Correct.
And this show is partly a byproduct of that meeting, among others. I've traveled across the United States the past 2.5 years, meeting with CMOs and in speaking with you and working with you in Boston. And it is clear that chief medical officers benefit from having a platform to share their learned lessons and to help each other in one of the loneliest roles in healthcare today, at least the loneliest one I can imagine. And I suspect you've learned quite a few things that are worth sharing along in your journey to becoming a CMO. So let's start with you telling our listeners how you arrived at the position that you're in now as Chief Medical Officer.
Certainly. Thanks, Lee. I can start with I was born in a log cabin. No, that's too far back. I think after residency, I realized that I could provide good one-to-one care with patients. And I really started thinking about how could I affect the healthcare of more than one patient at a time. And then I found this thing called leadership and understanding that as a leader within a department or an organization and working to set policy and procedures, I can affect the care of more and more individuals, right? So with that as my basis, I started to think about how can I get the skills and knowledge that I need to do what I wanted to do. And so, as you mentioned, I do have a master's in health policy and management because I thought that as a physician, if physicians made the policy for patients, it would be much better for the patients. And so after completing that, I really couldn't find much in policy in terms of career. So then I started thinking about becoming a leader within a hospital. And I was very intentional in setting goals for myself in terms of what leadership position I wanted, and then figuring out knowledge and skills that I needed, and actually seeking out people in those positions to find out what they felt they might need in order to get to where they are. And so with that as my background, I spent 15 years at Brookdale Hospital, which is one of the Brooklyn Health facilities, where I served as chairman of emergency medicine, chairman of ambulatory care, president of the medical board, and really started learning about hospital-wide issues. Started going to revenue cycle meetings so I could learn about revenue cycle. And so doing those types of things really helped set me up to be a leader within the organization. And I was able to affect the health of more and more people in Brooklyn. An opportunity came up for me to go into college health, which again, I felt that here you have a young captured group of individuals where you might be able to not only affect their care and their knowledge of their care, but they could take that information back to their families, and you would have a much broader capture, if you will. With 50,000 students at NYU, it was a huge organization. It was a global organization with campuses in Abu Dhabi and Shanghai, where we had health personnel, and I served as the medical director. I put several things in place to really help affect the care of the students around the globe, which was a great opportunity for me to learn about global health. And then after a couple of years, I started missing the hospital. And so I started thinking about where I wanted to be next. So my next goal became CMO. Even though I was the CMO at NYU Student Health, I wanted to be within a hospital setting or a health system. And so this opportunity at Lincoln came up, and I started on April 13th, 2020, in the middle of the pandemic in South Bronx, where we had gone from 32 ICU beds to 200 ICU beds in a short period of time. So that's how I got to where I am now, and was really the goal of affecting health of more and more people at the same time.
So it's a wonderful origin story with a few twists and turns. And I'm curious a little bit about the things that you learned in your master's program around policy and management, and then adding the layer of the intentionality and then the working with the students. I would imagine that not all of the skills of those environments would necessarily prepare you to become a chief medical officer. So I'm curious about, you're living in this role, and I've been in this role, and I was in the pandemic in Florida while you were in the pandemic in New York. Do you think that there are things that you learn on the fly about being a chief medical officer that do not necessarily come from the classroom? And maybe you could speak a little bit about the master's education and that other work, and then landing in the chief medical officer role.
Certainly. I think that from an educational perspective, a master's in health policy allowed me to learn how to read, interpret regulation, and then figure out how that regulation would affect people's health, and then how to rewrite it so that it seemed to have a better outcome for the individuals and groups of patients. So that's how that fit in. I did go back and a funny story, one of my master's professors said, if you really want to do health policy, you need to go to law school. And I was like, but I don't want to be a lawyer. I just want to do health policy and write regulation. And after thinking about it for a couple of years, it seemed like a great idea. So I went to law school at night and finished at Fordham and back in the late 90s, and actually was able to get involved in health policy and regulation at the local, state, and national level. So at the local level, running our EMS council, at the state level, chairing the New York State Medical Standards Committee for the Department of Health. And then I also had the opportunity to participate in Medicare rulemaking committee for ambulance fee schedule for Medicare patients.
Now that's quite cool. Yeah. That's very interesting.
Yeah. So that was gave me a really good introduction into health policy, regulation, changing regulation, setting standards for pre-hospital care. I think the best thing that we did with that group was really to define what constituted care in the back of an ambulance so that Medicare would know what happened and they would pay for. So that was a big deal. Took about a year and a half.
Well, that answers my question elegantly and eloquently. I think as a chief medical officer, we are faced with bylaws, rules, regulations, policies relative to the medical staff. But as you mentioned earlier in the interview, there's a lot more that can be done at a policy level, and the translation between how something was written and how it affects the human beings at the end of the day. And to the ability, it sounds like you learned how to become a universal translator and writer, because one of the things that I think, a buddy of mine who is a healthcare attorney says you really have to learn how to write, and you have to learn how to write the policy. It isn't just understanding it and defining it, but writing it for yourself. And I think that is what I'm hearing from you. Yes?
Yes. Yes.
Yeah. And that can apply to so many elements of the chief medical officer. Now, every chief medical officer role is slightly different. If you've met one CMO, you've met one CMO. But it sounds like you really achieved a wealth of knowledge that others who are listening to the show might think, that's the way I want to approach this. So I appreciate that origin story, because it might give some direction to folks who either struggle with those issues or think that's their sweet spot to enter into the role. I'm curious about the intentionality a little bit more. Were there any mentors or individuals that you attached yourself to? And you don't have to name names, but what was their role, or what did they display to you that you wanted to emulate or model for yourself?
So I looked for role models and mentors that I thought would be able to help me think through my career, my goals, and help me identify how I might get there. One of the individuals that played a big role was the executive vice chair of the New York Presbyterian Cornell Board of Trustees. And I had met him at a meeting when electronic health records was like first coming out. And I just walked up to him and introduced myself and asked him if he would, speak to me about electronic records, my career. And he invited me to his office at Cornell, and he spent an entire hour with me, just helping me, letting me talk about my career, giving me some thoughts. And that was really a great experience. And after that, I was able to keep in contact with him, electronically over the years when I had questions or issues, and he would set up meetings for me with others. So I guess he might have been more of a sponsor than a mentor, but he played a big role in my thinking about how I could use my experience to become a CMO or a CEO at some point. I think that um, the things that I've done, Medicare, rulemaking committee, and other organizations really gave me an opportunity to see how I can bring together groups with disparate issues, right? And so that's really been helpful in being a CMO is because we have to bring everybody together and get them to consensus.
Absolutely. That is a skill that we are not taught as young physicians in training. We're taught to be autonomous, independent. The buck stops with us, and we have to be prepared, right or wrong or otherwise, make a decision. That is entirely different than collaboration, consensus building. So it sounds like this person was both a mentor and a sponsor, and they had your well-being in mind, your best interests, and that certainly is a definition of a wonderful mentor who's thinking more about you than themselves. We're going to switch gears a little bit because I want to know what you think other people think about you. And I believe you can separate people into three simplistic categories, and you are free to argue with me if you'd like. The analytical folks, the aggressive folks, and either appeasing or diplomatic, however you want to look at that. And, you could describe three archetypes of physician leaders: Dr. Osler, Dr. Michael DeBakey, and Dr. Anthony Fauci. And I'm curious if you would put out what you think your coworkers and your peers would say about you and describe you as either one of those individuals, or if you have another name in mind, please share what you think other people think about you.
So since I've been here in this role at Lincoln, I always try to demonstrate fairness in everything that I do, in every decision that I have to make. And so I think people would say that I'm very diplomatic. I do know how to bring people together and tell somebody that they were bad, but not make them feel bad. So I think that that's a skill. And I think I'm also a little bit analytic. So I'm not going to just pick one because, like Dr. Fauci, what I found is that if I want doctors to do things, I need to give them the data as to why it's important for them to do it this way, right? So whether it's talking about coding a chart, putting in the right diagnosis, using the right words in your medical note, it's really about, getting providers to understand the evidence and the data. And that's really been helpful here.
Yes, I think that you kind of hit the nail on the head as a technique that CMOs need to remember, that when they're working with physicians, they are, for the most part, practicing physicians. That's usually who we're interfacing with. And that data is how they've been trained to think. And if you try to come at it from you have to do it this way, or you must do it this way, but let them come to the conclusion, more often than not, when presented with the data, they come to the right conclusion, or offer a different hypothesis, but still eventually get to the place you would like them to go without making them feel bad, without telling them what to do. So I would agree with you. It's also ironic that you mentioned that, because in the 80s, when you and I were living, about a mile apart from each other in Harlem, that's when Tony Fauci really got his claim to fame, being right out there in the midst of what was going on with HIV, which devastated a lot of our healthcare systems with just unknown intensity. We just didn't know a lot about it at the time. So it's interesting that we have that shared history. Aside from, and in that vein, aside from the pandemic, what do you think was the hardest thing you have faced as a chief medical officer over the years in the role? Any specific event or episode come to mind?
Yes. When I first started here at Lincoln, one of the things I began doing was began meeting with the residents. And I met with each program, residents separate from their program director, their chief, their faculty. So it was just me and the residents to give them an opportunity to have direct access to leadership. And I've been doing that now for almost 3 years. And I think during that time, learning about some of the challenges, and I'll give you an example that residents have gone through here, and I'm sure other places, was in one department, there was historically the attendings and the program director yelled and screamed at residents, right? And that was the old school way of teaching.
Yeah, Lewis, this is shocking. I never heard of this before in my entire career. This is unheard of.
I know.
Yeah. Go ahead, please.
But after speaking with the residents in this department, there was a room, and they called room number 8, where an attending would take a resident and they would yell and scream at them in that room for whatever the attending felt they did wrong. Right. The same department, the program director was using racial slurs towards residents of color and female residents, and just making terrible jokes that I'm sure they thought were funny. And I wound up getting rid of them because I just wasn't going to allow that to continue. And the residents were very grateful. The department character changed, right? Became more collaborative, more educational, no yelling and screaming. And so that's really been one of the hardest things I've had to face, is that was actually still happening.
So even in present times, you found yourself seeing that toxic culture, if you will, even today, and you had to do something about it. Correct?
Correct.
Yeah. They a lot of management gurus will tell you it is a lot easier to start a culture than change a culture. And I would tend to agree, but sometimes it's a must, and it is hard because it sometimes comes at somebody's sacrifice in order to begin to reshape things. So, in the same way that we're talking about some tough challenges for our listeners, what was perhaps the biggest fire you had to fight? Somebody didn't agree, or a group didn't agree with you, and you were able to put it out. This is where your diplomacy skills come into play.
I know. I think it was really the biggest fire I had to put out was the ongoing battle between the Department of Medicine and the Department of Surgery. I know. But here was at the leadership. It started at the leadership. And even at like one of the first meetings when I started here, the chairs of those two departments were going at each other at a meeting, and I had to stop the meeting and pull them out and have that conversation that, as leaders, this is not how you behave in public. And so I think that once I did that, they changed almost immediately. They started working together, and that's been stable now for 4 years, 3 years.
How would you, so a young physician aspiring to become a leader, what would you label that technique? So you have two individuals misbehaving semi-publicly, meaning in a meeting, not in front of the entire organization. So how would you label that tool? What would you tell a younger physician executive? What is that? What is that firefighting tool that you brought to the fire?
I'm going to say it's like a pickaxe. So when you see something that you need to break it down. Sometimes you need that pickaxe in order, like a firefighter, to break down a wall or break through a ceiling. And I think that that's what I would call it. It's time when you have to make a decision on the fly. And you sometimes, as a CMO, you have to stop what's happening, right? You can't let it continue. And that's happened a couple of times since I've been here. I've stopped one other meeting because a doctor was yelling and screaming at uh, the manager of this program, who was a nurse, to the point where she was in tears. And I just had to end the meeting and kicked everybody out except for those two. And then I used my pickaxe.
Yeah. Yeah. Good use of the pickaxe.
Yeah.
And of course, we are skilled at that. We are skilled at decision making, especially in emergency medicine. You don't always have the luxury of just watching the house burn down. You have to come in with a pickaxe, a shovel, a fire extinguisher. You have to be able to make that decision. And sometimes as we go down that executive pathway, we sometimes tend to forget we know how to call the shot, make the decision, whether you're in emergency medicine or pediatrics or neurology. The physician makes that decision. The physician executive is very skilled, but they sometimes don't realize that they already know what to do. They just have to act on it. So that's a great story. What do you think is the hardest aspect for you personally of your job or your role? You're thoughtful, you're educated, you're diplomatic, you use the tools at your disposal. Surely along the way, something you realize there's a gap somewhere or a personal challenge. What was the hardest aspect for you as you've experienced this role for you personally?
So I think for me personally, taking on this role as CMO and knowing that you are always available, right? And so whether it's during family time, holidays, vacations, sometimes you just have to be the one. And I think that for me, while it was probably the hardest aspect of this job, in my career, I've probably always been on call, and as department leadership, sometimes you're always have to be available. So I think that was one of the hardest aspects, but I've gotten used to it. And I've gotten to the point where I trust people that work for me and I trust their decisions so they don't have to call me with every little question, right? I think one of the experiences I had was at Brookdale at a meeting, and they were starting to get into what's called groupthink, right? And the CEO said, all right, let's stop, folks. Dr. Marshall can make the decision. We don't need to do groupthink. And I thought that really hit home, that I can make the decision. And I think that as a CMO, we need to remember that we can, like you said, we can make those decisions, right or wrong. But sometimes you just have to make.
Sometimes you just have to make the call so that you can move forward to where you're really trying to get to. So as a practicing oncologist, I used to tell my patients, I'd love to cure myself out of a job, or I'd love somebody to find the cure that I don't have to do this job. I don't know what I would do, as I love the job, but I wanted to cure my way out. And another one of our CMOs that has been on this show previously made a great analogy that as a chief medical officer, as a fire chief, it is helpful to learn how to prevent the fires, and empowering your people and trusting your people and shaping the culture so that you are not always grabbing the hose or the pickaxe and somebody else is doing some preventive maintenance, finding the exposed wire or where something might spark up, and nip things in the bud earlier so that you're not constantly pulled in 50 directions or called at all hours. I think it is a responsible thing to do for a chief medical officer to always be available, aside from being on vacation or family events or family issues. But if not managed well, it can be detrimental to the well-being of the chief medical officer. So that also takes a little bit of thinking about how to grow into the role and not overwhelm yourself, right?
Mm-hmm. Yes.
Yeah. Good stuff. What would you say to your younger self about becoming a chief medical officer?
I would say start earlier. No, I really mean that. And when I meet with the residents, I always offer them to sit with them to talk about anybody's interest in leadership. Because I think had somebody done that for me when I was a resident, I may have been farther along earlier, right, in my career. Not that that didn't happen, because as a resident at Harlem, I was on the medical board and president of the CIR at Harlem. But really to be able to help people think about where they want to be in 15 or 20 years, right? Because the residents are coming out, they're going to be clinical, they're going to take care of patients, but at some point they're going to need to think about what else they want to do, how else they can be helpful. And I think that we start earlier and making those offers when they're residents will help them get there, or at least think about it, more timely.
Yeah, I would love to spread that gospel, as I am now formally in medical education, having been a CMO. It is a rather curious time that our students come from a different place in life than when we were students, and they're exposed to things that we were not exposed to, namely the pace of change, the volume of information, the quantity of knowledge that has exponentially blown up in the last 10 to 15 years. So if you think about what you would do in your career, whether as an emergency medicine or as an oncologist 30 to 40 years ago, the quantity of sort of mental activity and the things you're doing, notwithstanding charting in the EHR and all the other administrative tasks, you're probably doing a lot more with the new residents today, not work hours related, but the unit of activity per hour is probably a lot larger than what we experience. The differential diagnosis, the tests. You and I had one flu A and B test. Now you do the 21, 22, 25, 100 respiratory pathogen panel in the emergency room. There's a lot of cognitive activity going on because then there might be different drugs depending on which pathogen you're dealing with, as opposed to, well, you have the flu, go home, or you don't have the flu, go home. You kind of tell them the same thing. So it gets very peculiar. And that's a long way of saying that I think that as a result, we should be telling our young students and our trainees, you may not be doing this for 40 years. The arc of your career may move as the world shifts and changes, and you may need to think of doing something after a period of time. You may need to sub specialize. You may need to go into a leadership role. You may need to be more entrepreneurial. And I'm really excited about that. I think there will be a brain drain because when you have had decades of experience, you're a pretty good clinician, assuming you're keeping up. But that's a challenge that we're all going to have to face. What are your thoughts on what I just spoke about?
So I think that you're hitting it right on the money. I think that, there is so much more information available and so much data that we're, as they say, drowning in a sea of data. And how do we parse through it and utilize data that really helps us improve care? And I think that the people coming out today are going to be challenged with that, and challenged with, like you said, you're not going to practice internal medicine for 40 years. You're you're not going to be a hospitalist for 30 years. So we need to think about how to help them find the path. And I think that will ultimately help patient care, right? I mean, that's the goal.
Yeah. And I think back to some of your opening comments, I think we should encourage more physicians to attempt to get into roles where they're shaping the policy that affects large numbers of people, because non-physicians have been owning that, rightly or wrongly, and it has shaped the way people experience health care, preventative care, or sickness. And so there's some value in encouraging that evolution of how we rebuild or reconstruct the house of medicine. So this is great stuff. We're getting close to the end here. I want to ask you one last big question. What do you think is the biggest fire within healthcare, in your opinion, right now? And the second part of that is, what can a CMO do about that, if anything at all?
So I think in my perspective, one of the biggest fires we have in healthcare is recruiting. I think recruiting physicians, specialists, subspecialists, especially when you start talking about safety net systems, and how do we recruit young specialists to come into underserved areas to provide care? And I think that's really challenging from several perspectives. One is maybe location of the hospital. Like, while the South Bronx is sunny, it may not be where people want to work. But going back and, helping to recruit, the CMO's role I see as making the environment that people are coming into, that we're recruiting doctors into, is a safe environment where they feel safe to provide quality care and speak up if there are issues. And I think that I think recruiting is going to remain a challenge, even with the CMS getting additional residency program spots. I think it's still going to be a challenge for healthcare. But as a CMO, I can make it a nice place to be, a nice place to work. And whenever we have a new attending come on staff, I go and meet them. I give them some swag and my cell phone number and welcome them to the institution. So
that's great. Culture does begin with onboarding, right? So
yes.
You get them off on the right foot. Are they the right fit? What motivates them to be in your community? Or in our case, say some of the reservations in the Four Corners, New Mexico and Arizona. What motivates a student to want to have a practice life there? And how do we support that and make that safe and healthy to give them that opportunity? Yeah, totally agree with you. Well, being a chief medical officer is no small task, and it takes intentional preparation, as you described, although sometimes it feels like a trial by fire. And in fact, my old boss told me that it is just like a career in firefighting. You start by going to firefighting school, and you train and you drill until you're ready to fight a fire, and you put on the uniform. You start out as a fireman or a firewoman. And one day, perhaps you find yourself being called the squad leader or the captain, or then perhaps the fire chief. And my boss always told me, you cannot be a fire chief without first becoming a firefighter. Would you agree with that?
Absolutely. I think one of the things I've thought about in several places is putting together a firefighting team so that as the leader, I don't have to respond to every thing that happens, right?
Mm-hmm.
You have a designated group that will go put out the fire, smolder the embers, and then come back and report, and then let's fix what happened. But that's my next goal, is to form that firefighting team. And I think that, and I didn't mention this earlier, but I did spend a few years as medical director of the New York City Fire Department, as a medical director for EMS. So I'm well versed in firefighting.
Unbelievable background, Lewis. We somehow we're going to have to do a chronology of your life and see what else we missed. So, well, it's been a real pleasure having you on the show, Lewis. I believe our audience will agree with me, and there's a lot of lessons learned, so I appreciate it. You've been listening to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. Want to learn more about what it is like to be a CMO? Want to be on the show? Email me at leescheinbart@gmail.com or connect with me on LinkedIn. You can listen to the podcast on Apple, and you can also watch the full videos of the shows on YouTube. Our show's website is thefirechief.podbean.com. I love talking with CMOs from all over the United States, so please connect, leave your reviews and comments, and please share this with your colleagues. And in the words of Sergeant Phil Esterhaus, let's be careful out there.